Good afternoon, everyone. So, post-lunch session, welcome to Atlantis 2. Our chairperson today, Dr. Ajit Babu Majhi sir, to please come up on the dais. We have co-chairperson, Dr. Rajiv Jain, Dr. Rajiv Reddy Papuru, Dr. Vivek Dave, Dr. Ritesh Narula, Dr. Nitin Prabhudesai, and Dr. Saumil Seth. You can have the photograph. If the previous session speakers want to have it, they can have the photograph. And then we have our expert panel, Dr. Vishal Agarwal, Dr. Anshuman Sinha, Dr. Sachin Mahuli, Dr. Manish Bapai, Dr. Prakash V, Anand Subramanyam, and Vibhuti Kashyap. Please. So, I think it's a 55-minute session, so we have 10 speakers, 5 minutes per talk. Let's be quick on it. So we have, do we have Pramod Bende sir here? No, he's not here. Okay, so we'll start with our Secretary of Retina Society of India, Dr. Mahesh Ji sir, who will be speaking to us on early vitrectomy in young PDRs. What are the pros and cons?
Thank you, Srinivas. I will be speaking on young vitrectomy. Actually, what is young? It can be a type 1 diabetes mellitus patient, or more common now is type 2 early onset diabetic, which is a growing global pandemic. We have two types of treatment: delayed or conservative, where we wait for 3 to 6 months for vitreous hemorrhage, or early proactive treatment, where you don't wait for that much. In fact, it is called rapid bleeding and blinding disease, or florid diabetic retinopathy. These internet pictures show how bad that. So this is a patient, a 38-year-old doctor, Ayurveda doctor. I told laser, he didn't come. 6 months later, he came for a review. Again, I told laser, he didn't come. Then 1 year later, he came with vitreous hemorrhage. So surgery was done. So this is post-surgery. So there are problems with delay in surgery. One is irreversible macular damage due to ischemia, and irreversible ELM damage. So that is why, and definitely there is a chance of angiofibrotic switch if you do waiting for too much with injections only. And there are hypoxia-induced factors and role of insulin-like growth factor and angiofibrotic switch. The problems, other problems are lack of PVD, vitreoskisis, and anterior hyaloid proliferation, which are common in these cases. And vitreous will be densely adherent to the retina with multiple pegs, and it will create it will make your life miserable. So DRVS long time back in 1985 told early vitrectomy has some advance. At that time there was no finer instruments, but now we are living in a much advanced instrumentation era, and so definitely that has we can improve our results much better than this. There is another risk of delaying surgery in young PDR. It is called crunch syndrome. This was a case where we have given anti-VEGF and laser injection, and followed 2 weeks later, this was the picture where there was a dramatic crunch syndrome with detachment. So early vitrectomy means within few weeks, not months, for clearing the vitreous hemorrhage and do the definitive treatment of PRP. And it has to remove the scaffold so that oxygen distribution is better and definite treatment of laser can be done. There are different steps. All of us know the PVD induction and different surgical strategy, and minimizing the retinal breaks. So systemic control is also important in these cases, because there is a concept of diabetic vitreopathy with early worsening paradox if you control the diabetes too fast with the stickiness of vitreoretinal interfaces. So we all give anti-VEGF injections before surgery, but if you wait for too much of time, it can cause angiofibrotic switch. And these three problems, recurrent vitreous hemorrhage, neovascular glaucoma, and iatrogenic retinal breaks, are really troublesome in young diabetic patients. So, but many of them do well if you do early intervention with surgery. And many of them have renal problem, which you can consider retinorenal syndrome, renal retinal syndrome, and they usually worsen. And many of this PDR, when it reaches you, will be like this very bad schisis in the retina. And this is a case which young patient operated the right eye, and even after surgery, and oil removal, it was hand movements because of delayed surgery due to ischemia and optic atrophy. So this is another case. The left side, left eye was operated, nicely operated, but only hand movements because of bad optic nerve. So this will tell you the importance of early surgery. And so this is these two are immediate surgery within a month. A young diabetic, you can see that the membranes come very fast. But if it is a delayed surgery, the lower pictures will show the delayed surgery, how adherent the membrane is, and even if with a lot of difficulty you remove the membrane, ultimately it will end up with silicone oil injection and bleed. Actually, the lower part, right side picture, it was reasonably managed well with silicone oil, but the patient developed NVG and hyphema and NVG. But the upper case did well after surgery with a good post-op recovery of 6/12. So this both patients are around 38, 40, and one was managed immediately, the other was managed after multiple PRP and injections. So this will give you the summary of my talk. So next slide. Showing.
Yeah, I think
Yeah,
Mahesh,
over.
you need to conclude.
Yeah. So
Mahesh,
this is,
I want only one question
Yeah.
for you. That you said early surgery, late surgery.
that
If
is
the patient have 24 40 vision, not much of membranes, there are few membranes are there.
Yeah.
What will you do?
we wait for some time with mild laser. I am not telling 20/40 should be operated, but if there is a patient comes with vitreous hemorrhage, our tolerance will be little less.
Yeah, vitreous hemorrhage, I agree. But if the membranes are more than 20 40, what will you do?
I may not touch.
Okay.
Yeah.
Okay.
Thank you, Mahesh sir.
Thank
Next
you.
we have Dr. Naresh Babu sir. Before he takes up, I want the expert panel, like what Ajit Babu sir said, a patient of 6'9", young girl with minimal VMT and minimal peripapillary traction. So does VMT and peripapillary traction is the indication for your cause, or is there any other causes you want to do early vitrectomy in these young patients, boy or girl?
For me, I would want to operate if there is documented unequivocal either progressive vision loss or metamorphopsia, and even if there are bleeding episodes which are clearing in between.
6'9", VMT, peripapillary, no vision disturbance, no metamorphopsia.
No vision disturbance, no metamorphopsia is observation.
Observation. Okay. Over to Naresh.
Thank you. Thank you, Srinivas.
Yes,
Thanks
sir.
AIOC for the opportunity. So methotrexate is not a new drug as far as ophthalmology is concerned. So we have been using it for quite some time. And it has got anti-inflammatory property, and most importantly, it has got anti-platelet property. That is what is made use of by us while using it for the diabetic vitrectomy. So these are the basic indications which is being used. And now we are extensively using it in case of retinal detachment to prevent PVR cases. And the dose is variable. People use somewhere between 250 to 400 microgram. We use 400 microgram. It's arithmetically easy also to calculate, and it's not very expensive. We can go for serial injections. Usually we go for weekly injection. And with this background, the basic problem in case of diabetic vitrectomy is some silicone oil bleed after we inject the silicone oil, because most of these people are all on blood thinners, and there is a grade when the blood is thick, there is every chance that it will go for PVR and redetachment. So the inflammatory property takes care of this, but the antiplatelet property is the one which is very useful in this condition because it lyses the clot and results in the resolution. And why we have to inject serially? Because a very short half-life and slowly diffuses over a period of time, and the PVR starts quite late. So it helps in when we do it in multiple injection, it is really helpful. So this is our experience which we'll be sharing. Like in the cases where there is a subsilicon oil hemorrhage following the diabetic vitrectomy, we started using 400 microgram in 0.1 ml, at least 2 to 4 injections in all these cases, and they were divided into two groups, 15 in one group and 14 in other group, which was not receiving the injection. So all these cases underwent vitrectomy with silicone oil injection, and the total injection ranged from 2 to 4. So these are the things which we have done. We found that the demographics are similar, and this is the frequency of diagnosis in both the arms. And we found that the visual acuity was better in the injection group, as well as the prerectal hemorrhage, which was more in the injection group. It became much lesser after multiple injection, and it was statistically significant. Rebleed was seen only in 3 cases in the group where there was no injection, and redetachment in the non-injection group. So this is case number 1, 2/60. You can see extensive hemorrhage under the oil and POD8. The vision was CFCF. So this is after 16 days. We have been giving injections. So after multiple injection, no procedure was done. So we could see that the complete resolution of the blood under the silicone oil. So this is another case. You can find there is a TRD. The patient had minimal hemorrhage, but still we injected. So complete resolution improved to 5/60. This is another case. Extensive hemorrhage with the vision of hand movements, multiple injections, complete resolution 5/60. This is just in 21 days or 30 days. And by 30th day, the vision is 6/60. A complete disappearance of the membrane and improving to 6/36 in 45 days. So this methotrexate, we have seen the cases where there is a complete resolution in most of these cases, quite useful. But we have seen people using bevacizumab or ranibizumab in cases of subsilicon bleed. This is what I was saying. If it's a grade 4 bleed, there is every chance that the patient will go for PVR. So they have used anti-VEGF, but we are the first one to use. But there are a lot of evidence of this methotrexate being used for PVR changes, where they found that the redetachment is very less. In fact, this is one of our publications. My friend Dr. Renu is the primary author for this, and we found the redetachment is much lesser in PVR group. So this is our experience in the PVR group, and this is quite useful in case of PDR also. So basically, the anti-platelet property as well as the anti-neoplastic, the anti-inflammatory property of methotrexate is very useful. And this anti-platelet action, which helps in the promotion of apoptosis and as well as by inhibits the enzymes in platelet function, and this leads basically to the lysis of the clot. So when we are using a 400 microgram in serial, resolves the hemorrhage and prevents the proliferation under the silicone oil, and in fact, it definitely helps in the outcome of diabetic vitrectomy in TRD cases. So these are the cases. Just thank you.
Thank you, sir, for bringing in new insights. From the expert panel, any people have experience of using methotrexate in diabetic vitrectomies? No. So
People are using.
now people are using. So apart from diabetic, danirubicin is also can be considered, or only the
We are now using topotecan also actually, because I think a lot of trial going on with topotecan. We are comparing topotecan with methotrexate. But the one
in which cases do you think it best suits the well? In diabetic vitrectomies, which are your criteria for the main 1, 2, 3 criteria for using methotrexate?
we are not going to use intraoperatively. Only if the patient is
Post-operative.
going to have bleeding under the silicone oil, especially in cases where there is a renal compromise or on blood thinners. In such cases, when the bleeding happens under the silicone oil, in such cases we
And the possibility of reproliferation?
very minimal in this case.
And have you compared, like you said, at 45 days the blood cleared?
Yes.
And have you compared without any treatment, self-resolution was also in the same period, or it did not resolve?
No, we have compared actually. The result says that the resolution is statistically significant in the injection group compared
next
to the non.
speaker should come
In
here.
fact, the rebleed is more in the non-injection group. Redetachment is also seen in the non-injection group, which we have not seen in the injection.
Dr.
Yeah, thank you. Can we go on to the next speaker, please? Dr. Jayant Kumar Guha. Thank you, Naresh sir, for the wonderful presentation. And after Dr. Guha, we'll have Dr. Darayas on this part of the stage.
So after putting around 13 injections of methotrexate, we'll concentrate on a single-use application of mitomycin C, one-time application, to prevent because it is used both in PDR and as an anti-proliferative agent in recombinant RD. In this presentation, only recombinant RD is being discussed. So we all know the average incidence of PR. I'm not going to details. I'll skip many slides to go to the video first. So the trauma cases and the pediatric cases are at very high risk of PVR, as we all know, with a very high rate of resurgeries. The main treatment I want to emphasize is still meticulous release of traction and sealing of brakes. One should not treat mitomycin C or methotrexate as a substitute, but only as an adjunct, because over the years, in spite of all the advances of which the Vivek has spoken about in machines and fluidics and instrumentation, this remains the bane still till today. So we must have an adjunct after the meticulous surgery. So these have the agents. I won't go into details. Methotrexate has been dealt with, but the number of injections and the cornea toxicities and many other things, this is not a debate between me and Naresh, so I won't go into details. We all know the uses of mitomycin C currently is used in various surgeries, and it has been proved in animals about long-acting nature, toxic effects, and also inhibition of PVR. So ASI has started this, but he uses a sponge dipped in mitomycin C in air-filled eyes. I'll be demonstrating Gokhan Gurulik, with whom I am collaborating in this, and this is, we all know how mitomycin C works. 10 microgram and 20 microgram are the two concentrations we use, thrice diluted, and sandwich techniques protects, the PFCL protects. I will show in the video. I think I should go to the video now. Please start the video. Yeah. So as I said, this is a case of extreme PVR with a taco-like situation, giant retinal tear folded on itself. Meticulous membrane peeling bimanually, the pull being horizontal always, tangential always, never vertical. And I will go on skipping for want of time. And then the retinotomy is combined. And in this, I'll just demonstrate, because if we use PFCL at such a premature stage, it will go behind. So I use a Helon or a Viscoat. This is subretinal membrane removal, and so this is one of the indications of in these severe trauma cases of using mitomycin C. And so I just wanted to highlight that meticulous membrane peeling is never a substitute, but is the beginning of the treatment of management. So this is a Helon PFCL sandwich, which keeps the retina attached, and after that's the end result. And I'll just go on to show how we use the mitomycin C. And so after having settled the retina, and sometimes we have to do a retinectomy, and then we under fluid air exchange in the interface, after doing the fluid air exchange in the interface, we inject the mitomycin C, and roughly 1.5 to 2 ml, but it's under direct vision. We just see so that the equatorial area till the ora has a rim of the mitomycin C solution, which is stained with blue, because otherwise it's transparent. So we mix the mitomycin C with brilliant blue, and then we wash away after 60 seconds the mitomycin C, do a thorough laser, and this is another case. And at the end we do a PFCL silicone exchange after washing away. So this is the mitomycin C solution being injected at the interface again. So I'll just go to the results. So sometimes we have to be very careful, that we have to be very meticulous with the thorough clot removal, because in spite of everything, there will be these will incite the PVR changes. So mitomycin C is only as an adjunct after thorough surgery. Sometimes in a 3C retinotomy we have to rotate, and I'll just show you the few photographs. The last results are coming up. So these are the results. This is an ongoing study. So this case, just to highlight, after multiple surgeries, maybe it won't help, but in the early stages, if fresh PVR cases or once operated maybe, then the edges absolutely merge with the RPE choroid. So these are the few examples after severe PVR changes. This is the last. This is a resurgery done elsewhere, and see the end result. Thank you so much for your kind attention.
Thank you, sir. Any experience of usage of mitomycin C for PVR from any of the expert panelists?
No. Are you
I don't
using?
use it in my practice.
Sir, Guha sir, just a common question. It's already the proven, it's an old kind of drug, and the PVR
No.
recurrences also. No. I'm talking about the drug per se. Even
Yeah,
the
yeah.
PVR recurrences also, if we see, where it is very less compared to methotrexate, it's already proven. Almost around 70 to 100% of reattachment rates. Many authors have already provided with methotrexate, and less reattachment rates or more risk of producing PVR in case of but why mitomycin C, sir?
No, the
It's
king
a single
is
or single
no.
application.
Wait.
Yeah.
See,
Single application.
MIVS by itself is so successful surgery now, even with advanced PVR changes, or these agents are required. That is number one. Number two, if you are using, there should be a comparative study
Of head to
and
head,
prove
yes.
beyond the doubt.
13 injections of methotrexate.
No, now
Is
the
a single application.
the
Now,
modified
they are
GARD
using
trial
long-acting methotrexate is coming up
methotrexate,
now,
yeah.
but mitomycin C and is much less toxic to the cornea also. Besides many other advantages, there is no time to get into these.
Yes,
but mitomycin
let
C
us
is
not
proving.
go into the arguments of.
Any other comments?
And I want to announce that Dr. Pramod Bende is not coming. He informed to the scientific committee much ahead of
No
time.
problem. Noted,
Okay?
sir. That is already noted.
Yes.
So I think we'll take it at the end if any other discussions are there. Now we have one more minute. Let's see. So now I call upon Dr. Daraya Shroff, so another ACE surgeon. So he'll be speaking on the recurrent retinal detachment, how to prevent, tips and tricks.
Thanks so
Vibhuti,
much.
you can come
This
up
is
on
one of
that.
my favorite topics, and I have to really go fast because it's a vast thing to cover. So although failure rates have gone down, this is something, a reality we have to face from time to time. When can it happen? It can happen after pneumatic retinopexy, after a buckle, or after vitrectomy. These are the causes: missed breaks, no breaks, but the most important is our bugbear of PVR. Management options are pneumatic retinopexy, adding a buccal, vitrectomy, or doing membrane peeling under oil. So just see for case number one. This is a patient 6'6", macula 1 RD, superonasal fluid, and a tear there after an injury with tennis ball. We did a buccal. You can see the wide angle, the OCT, the nasal OCT. And 3 days post-op, because I love imaging a lot, so this shows the retina is well attached. But this is the shocker. After 3 weeks, we find that there's fluid nasally. And we thought, okay, buccal, sometimes you can have fluid. We waited, but no. Look at the borders of the RD. They're convex borders, something is RD. This is where one of the tools which I feel really helps. This is gas injection, a rescue pneumatic retinopexy. So we injected gas, added laser superior quadrant, and you can see this tiny chintu, the tiny bubble now, and it's beautifully dry at 1 month. So why did it retouch? Because there was increased vitreostraction in that area, lifting it from the buccal, and vitrectomy would be horrible for this young boy because it caused cataract formation and been very invasive. Gas saved the day, rescue pneumatic, one of my favorite topics, and the second publication we published in conjunction with Wills Eye Hospital, where we did rescue pneumatic for our series of patients. So this is a step-by-step approach. When we need to do a revitrectomy, whatever is in the way, remove it. If it's a cataract, take it out. If there's an IOL, remove it. If you're friends with Vivek Dave, you can do an endoscopic vitrectomy. But at the start, decide what kind of gauge you want. Do you want a 20 gauge? You can have a hybrid infusion, and that was going to be wonderful. Adding a buccal is always really a wonderful tool, because you can have a circumferential element which kind of forms a posterior aura, and this gives a lot of support. Tackle the posterior PVR, remove the bands and subretinal oil, and if anterior PVR, which is the bugbear, is more, remove the uncut skirt, which is the bugbear and causing this problem. So let's move to the tips and tricks. This is supposed to have an audio. So this is a hidden break. This lady had a recurrence 2 years post silicone oil removal. There was an inferior shallow RD along with previous laser marks, but no obvious break was seen. We tried to locate the break with the help of Schlerin with a brush needle, but we were unsuccessful. We thought out of the box and made a 38 gauge retinotomy and slowly injected subretinal brilliant blue dye. As the dye filled the subretinal space, we had a eureka moment.
Good video.
We saw the blue dye emerge from a very tiny temporal break near a laser mark. Once the break was found, we removed the dye with a brush needle, then performed the fluid air exchange and settled the retina. The other maneuver, which is really my hot favorite, is called tug of war, so you can enjoy the video. In these cases, I like to perform a maneuver called tug of war, based on the shearing force a rope undergoes during the game. We use opposing forceps to tug and shear the membranes gently and relieve the traction without resorting to a retinotomy. See this young, highly myopic girl with circumferential traction bands predisposing to anterior PVR. This maneuver allowed us to bimanually release anterior circumferential traction. We took two forceps at 180 degrees to each other, then pulled and shredded the bands holding up the retina. Once the bands were separated from the underlying retina, they could be safely trimmed by the vitrectomy cutter. As the traction was released, the retina fell back and settled without requiring any retinotomies. With a sigh of relief, we performed laser to the attached retina. So this is something we published in the IGO tug-of-war bimanual technique for anterior circumferential PVR and retinal detachment. It's very, very useful technique. AMG is a new kid in the block. I think for lack of time, I won't show the video, but just to show this patient with this huge tear, axial length 30 millimeters, hand movement vision, and we kind of put a graft in. I think we'll skip the video, but you can see how beautifully retina is settled well, and you can see vision from hand movement. It's not great vision 660, but it's fair vision for such a case. You can peel membrane and MP under oil and tamponade. I have a video about Densiron, but there's no time, so we use heavy silicone oil. If you like, actually we'll be having this in my IC on Sunday, so everybody's invited to that. That's on Sunday at 12 noon. So this is the abridged version. You'll see the full version at that time. Thank you so much.
Thank you, Dr. Daras. That was a wonderful presentation. Showed so many various tips and tricks. Any other than what Daras has shown? Any other tips or tricks our expert panel would like to focus upon?
I think one thing can also be that. One thing that can also be is the application of a circumferential or encircling band. If you may not have put in the primary surgery, could also be something that you may look at as a secondary procedure. So it's not that in a recurrent procedure.
I think that's something I always do.
He
that's
mentioned that.
Very important point, yes.
Yeah, and the post-operative gas injection certain times for a residual detachment, we can work wonders. If you are seeing non-closure of the break, temporarily it can extend and then...
I think that's better than the primary one, according to me.
Any other comments from my expert panel? Dr. Rajiv Reddy Papuru is here, Dr. Bapai, they are sitting downstairs. If they want to make any comment, Dr.
Rajiv will also get him to do the endoscopy for us. I forgot.
I just wanted to, in your first video, rather than using BBG initially, would you have used the PFCL to bring it and look at the egress of the subretinal fluid, or in that contrast is lost?
The contrast, it was not sufficient. But it just happened. But it doesn't happen every time so beautifully.
And I think that was not that bullish, so the egress would not have been appreciated.
Not appreciated.
Not only that, it's a myopic eye and the contrast is not so great.
Not so great. Great. Okay. Thank you, Dr. Darais. Now we call upon next speaker, Dr. Gagan Bhatia, please.
Yeah, good afternoon, everybody. I'd like to thank AIOC for this opportunity. So when we talk about POVCH, we are basically talking about dispersed vitreous hemorrhage post-vitrectomy in a case of a PDR, where the incidences, as we see here, have reduced post the small gauge vitrectomy systems that have come. The POVCH can be classified basically as persistent hemorrhage when you see them on the first day, and early recurrent hemorrhage, which usually happens because of clot lysis or incomplete PRP, and late hemorrhages, which is beyond 6 weeks, which happens because of either new vessel growth or residual traction, and also entry side neovascularization, which can happen. So coming to risk factors, surprising, but this meta-analysis basically showed that, as we all believe that, stopping anticoagulants is extremely important, but that was not really the risk factor, for in this meta-analysis. Though CAD as well as younger age are two factors which do contribute to having post-operative bleeds. I personally feel that POVCH, though called post-operative, but it's something that starts in the OR, because these are steps that you take in the OR which prevents POVCH, starting from pre-operative anti-VEGF, membrane peeling, and the various steps as we go through them. So, preoperative anti-VEGF, as we already know, I think though it does not have any major effect on late recurrent vitreous hemorrhages, though early hemorrhages can be prevented with anti-VEGF. Yes, crunch phenomena is something that we do all know and need to tackle it whenever it does happen. Residual FAP causes almost 9 to 13% of cases causes POVCH. So I think completely removing all fibrovascular tissue is something should be the dictum, unimanually, bimanually, whatever one is comfortable with and whatever the case requires. But it's paramount important that each and every fibrovascular tissue is removed. Sometimes you have these small fibrovascular polyps over the disc, which sometimes can be left behind, but they do tend to cause post-operative hemorrhage and should be tackled. Intraoperative hemostasis is again one more step which is extremely important. I think first is you can do it just with the cutter. Second is a bimanual technique where you use a brush flute needle in one hand, a cautery in one hand. And this could be one. And the third way is this, where if you tackle a hemorrhage, you can use a cutter in one hand, and suction of the cutter helps to kind of clear the heme, whereas you can cauterize with the other hand. I think insufficient retinal photocoagulation is something which again causes a major concern for POVCH. So I think you could use a bimanual technique as here, where you can depress with one hand and complete the laser. So a complete laser is extremely important in these cases if you want to prevent post-operative hemorrhages. I think in cases where we use gas, I think sometimes because you have this thick residual fluid, so PRT is never complete. I think FFA acts as a very good adjuvant in these cases, and doing a post-operative FFA is important, and we can complete the laser to prevent any hemorrhage. This is one technique where I use to prevent post-operative hypotony. I know it is something which can raise a few eyebrows, in this era of not suturing the sclerotomies, but I think in diabetic cases it is important not to have hypotony, as it is one of the major causes again for this thing. So coming to the management, I think it is pretty clear. I think we all do it. It is observation, anti-VEGFs or revitrectomy. Surprising again in this meta-analysis, what I saw with Barar was that observation led to spontaneous resolution in almost 83% of cases, and this is probably pointing out to Srinivas, who was discussing in the first talk about the same thing. And anti-VEGF, yes, does work, especially for entry-side neovascularization. This is something where in recurrent cases I started using a UBM and found that these kind of fine neovascular membranes from the entry side and also the anterior hyaloid, where a revitrectomy and anti-VEGF kind of helped, and these membranes absolutely went away on a UBM. So as far as tamponades, again, we do know that tamponades help in they tamponade the fragile vessels, though and silicone oil is something which I don't usually use in PDR cases, but studies show that they decrease the risk of reoccurrences of POVCH. But yes, sometimes you're not very lucky, especially after you have cases like these where you have a huge bleed under oil. Though in this case we went in and we were lucky that the whole bleed came off. Now, once you're removing these oil, so under oil, when you're removing these bleeds, it is important that don't try to unplug that little clot that is there, because that is again going to lead to a recurrent hemorrhage. So just to conclude, I think though called post-operative, again I kind of would like to say that it all begins in the OR. So completing all your steps in OR is extremely important by adhering to the surgical principles. Post-operative FFA and UBM is something that we should use in an armamentarium in PDR cases, and something which is observation and timely intervention is a balance that we need to kind of maintain in these cases. Thank you.
Thank you, Dr. Gagan, for finishing before time. Any comments from the expert panel? Before that, I just want to ask one question. I recently, day before yesterday, before coming here, I just operated a lady who had a very bad pre-retinal hemorrhage, post-surgery, silicone oil. In these cases, putting an gas versus silicone oil, especially if there is no tear, in those cases, because with the tamponading effect of the silicone oil, the subretinal hemorrhage, even if it develops very badly, and it gets stuck to the retina so badly that removing that almost becomes impossible. And sometimes inadvertently we try to pull it. So I could just clear only up to the fovea after 1.5 hours. Till 1.5 hours, I could only clear up to the fovea. Any tips and tricks of disadvantages of putting silicone oil in these cases, because identifying these cases preoperatively or intraoperatively, so that we can prevent these kind of very bad suboil bleeds?
I think it is one situation where prevention is better. I think the approach should be that usage of oil should be the last thing on your mind. You should look at sealing all the breaks. In fact, I feel you can spend about few minutes at hypotenuse levels at the end of your surgery with your diathermy in hand. Look all around the retina for any potential bleeder. Laser them, like he said, peripheral laser. I would say even do an ARC if you're, if you feel that the periphery is ischemic. So putting oil for the sake of stopping hemorrhage sometimes can lead to the situation what you said.
Yeah.
I just want to make a point that the lens status is a big impact factor for post-operative vitreous cavity hemorrhage. So I've seen most of these happening in phakic eyes.
Yeah, because
so
of
even
anterior hyaloid
because
being
you cannot
intact.
clear, it's impossible
Yeah.
to clear behind the
Anterior
lens.
hyaloid
So it's
is
always a
intact.
good idea either to do a combined surgery or a stage surgery,
Stage
but make the patient pseudophakic, and that you can clear the vitreous hemorrhage
that's
more
a good point.
more
Yeah.
comprehensively.
I just want to add there are two things. One is the blood which is already in the peripheral skirt of the vitreous. So patients who have dense vitreous hemorrhage always try to indent the periphery and remove as much as vitreous as possible, because the blood in the peripheral vitreous skirt which is left, it comes to the vitreous cavity and may take 2 to 3 weeks for it to clear. And at the end of the surgery, especially all diabetics, lower the pressure, make it around 10, wait for 30 odd seconds as Vivek has said, and see whether the blood vessels are oozing or not, because these are the two steps which prevents persistent vitreous hemorrhage.
But
if you
even if
Yeah,
it bleeds,
before-
Dr. Rajiv sir, under air, you're talking under air, right?
Yes.
So under air, identification of the bleed also becomes very difficult. We do not know where
Yes.
the
So you
actual bleed
you
happens.
can go back to
Fluid again, you have
Yeah.
to go back.
Actually, you should dry the heme before you decide whether you put gas or oil. And oil is advantageous because it will prevent the dispersion of VEGF, so that aggression of the vessels post-operative will be less. Whereas gas is also helpful if you are very sure that you have cleared everything, and then the healing will be better with gas.
So just a closing point, if I can. So I personally feel that I think one point which is very important is that residual fluid in PDR cases should not be the factor for putting gas or oil. Secondly, I think oil should primarily basically be used if you have a break which is in inferior quadrant or a break which you cannot laser completely. I think that is one of the main factors where you should only think about putting oil. Otherwise, I think residual fluid should not be the factor for deciding this thing, because residual fluid will definitely go away in PDR cases. So that's extremely important. So I think judicious use of oil is the first step that you can take in preventing all these complications. Yeah.
Thank you, Dr. Gagan. That was a wonderful presentation and nice tips by all the expert panelists. The next topic, I want Nitin Prabhudesai sir to make a few comments. So I now ask our another speaker, Dr. Avninder Gupta sir. He'll be speaking to us on expulsive hemorrhage. All is not lost.
First of all, I'd like to thank AIOS for giving me this opportunity. I'll be speaking on management of expulsive hemorrhage, saving the lost. Expulsive choroidal hemorrhage is a rare and dreadful complication of phacoemulsification or VR surgery. It results in either loss of vision or loss of eye. But incidence of expulsive hemorrhage has decreased markedly because now we are working in a closed system like phacoemulsification and vitreoretinal surgery. I will not go in pathophysiology and causes of expulsive hemorrhage. I'll straight away go to my first case. A 56-year-old female had injury with badminton stick, came to us with severe corneal edema. Details of anterior segment was not clear. Patient had very high intraocular pressure on maximal anti-glaucoma medication. USG showed no RD or CT, so we took this patient for surgery. So after putting my all the three infusion, I started clearing the anterior segment, and once I cleared the anterior segment, I realized that all of the lens is in anterior segment, and that was the cause for high intraocular pressure. So if I don't release this, remove this lens, and the pressures will be high. After a period of time, what you see here, there is a fresh hemorrhage which is coming. I thought that this blood which is coming from the posterior segment is a blood after trauma, and it's again coming into the anterior segment. So I started clearing with the other port. The blood kept on increasing, and now you see here this area, you can see the blood coming out from the sclerotic. At this stage, I thought something is wrong. I looked at the blood pressure. Blood pressure was 240 by 120. I called my anesthetist. Sir, please look at it. I closed the port, increased the intraocular pressure to somewhere around 40. And then uh, sat for 10 minutes. The blood pressure came down with nitroglycerin drip. Now the dilemma was whether I should proceed further or I should just close it. But if I close it with the lens in the anterior segment, I'll lose the eye. So what I planned is I wanted to remove the lens. Since the infusion is there, I increased this pressure to 60. I made a large tunnel so that I can remove this lens in one go. And with this, I removed the lens in one go with irrigating wire vectors. Uh, Lucky for me, this expulsive hemorrhage didn't increase over a period of time. Went ahead, did an vitrectomy in this patient, and I saw was a mound here, so I created an sclerotomy and went till the suprachoroidal space and retracted the sclera, and you can see the blood coming out. Uh, After I have drained this choroid, I went inside, did an PVD induction in this patient. You can see there is an choroidal mound here, and now I am pretty bold that I can manage everything. Suddenly, this iris comes out, and in putting this iris here down, I create an hypotony, and you can see here. You can see the choroid coming from the nasal side, so the bleed has occurred from the nasal side. Now the tension comes, I put PFCL, and since it's a vitrectomized eye, put PFCL in the eye, drain the choroid from the nasal side, and did a PFCL silicone oil exchange in this patient. You can see this choroid is not drained, but the nasal choroid has been totally drained. So with this maneuver, I was able to salvage this eye, this patient. This is 1 week post-operatively, and 1 month post-operatively, this patient improved to 660. Later, this patient went on to improve to 6.9 vision, and I did root SFIUL. This patient is maintaining 6.6 part vision at the moment. This is another patient. I was doing angle closure glaucoma. I was doing SFIUL, and suddenly you can see there is an choroid, and you don't see so much of blood in anterior segment surgery. You retract the lip, you create an sclerotomy at the highest point of choroidal bleed, and you can see I have drained this choroid. At this stage, I've abandoned the primary procedure of SFIUL, closed the wound, and I was able to salvage this patient again. To my luck, improved to 612 vision. 3 to 4 months down the line, I did an SFIUL into this patient, and this patient is doing good with 612 vision.
Either seconds
In situation 2, the close,
We will
if
check
no
it.
drainage is possible, close the wound with sutures, control systemic blood pressure, wait for 10 to 14 days for blood to lyse, then via surgery is performed to salvage this eye. This video I have borrowed from Ritesh.
Avneet, time is up.
Yeah,
So,
only last.
no, extension because already we are running late, very
Okay,
late.
okay. So to conclude, infusion cannula AC maintainer is a must to maintain IOP and drain the choroidal drainage. In the era of self-sealing wounds, most of the eyes can be salvaged. If possible, drain the hemorrhagic choroid by making sclerotomy at the highest point of the CD. If CD drainage is not possible, control IOP and inflammation. These patients can be taken up for vitreous surgery after 2 weeks. Timely intervention can salvage most of the eye. Thank you very much for your attention.
Thank you, sir. That was really challenging cases what you showed. Nitin,
Yes, especially in the first case, you think that the blood pressure was a cause for this problem?
High intraocular pressure and blood pressure. This high IOP was somewhere around 48 before surgery. I gave mannitol to this patient. I took all the precaution, but suddenly the blood pressure went up. Once the bleeding started, I saw on the monitor it was pretty high.
Otherwise, I think very well managed. But I think we usually wait in cases of because we see a lot of patients with neovascular glaucoma. We wait for at least 4 to 5 days with the pressure being low because otherwise such problems are.
yeah, that was a question to
No,
ask again.
this was not immediate surgery. We waited till 3 days and we took the patient for surgery after 3 to 4 days.
In your first
The
case.
IOP should be normal for at least 2 to 3 days before you take this patient because
No, but it was not coming to normal. It was on maximal anti-glaucoma medication.
The lens was in the AC, so
Yeah, it will not come.
Avanindra, the first case, you have made the tunnel, but it should be sutured once you deliver the nucleus.
Yes,
You are
sir.
very lucky you get away with the whole thing.
Agreed, sir. Agreed. I actually sutured it in the last, sir.
So thank you, Avninder sir. We have a last presentation for this session. Dr. Anirudh Maiti from West Bengal, another ACE surgeon. So I request him to speak on ERM VMTs, when to operate, especially when it is 6/9 also. Please consider that.
Thank you, Srinivas. This presentation was mainly meant for the anterior segment surgeon because this is a very common scenario. Either we are getting an incidental finding of an ERM or a VMT before the cataract surgeon, and they were pretty confused what to do: refer to a retinal surgeon, or go ahead with a cataract surgeon. So we are not going to the pathogenesis of ERM. We all know that it's an anomalous PVD induction which causes it. Diagnosis, sometimes we are in doubt about the VMT, then the OCT needs to be done. Otherwise, the slit lamp biomicroscopy can easily diagnose. The ampulla gives an idea whether the patient is symptomatic or not. Now, what are the symptoms? Because the entire thing, whether we need to refer or do a surgery, depends on the symptoms. It may lead to the loss in visual acuity, metamorphopsia, difficulty in using both the eyes together, or the patient is having an diplopia. Now, coming to the main topic, that is follow-up or surgery, what is important is the patient should be informed that majority of the epiretinal membrane will remain relatively stable and they do not require any therapy. And if you see with the statistics, like 29% of the ERM actually progresses over 5 years, rest 26% regress, and 39% is status is same. And in eyes with VMT of 1500 microns or less, the patient often have a very stable visual acuity. And there is a chance of spontaneous release of this traction from the macula in almost 23 to 47% of the eyes, which is quite significant. Now, there's a few of my patients that post-RD ERM, there is the third case was and CNVM with a VMT. So these are the cases we follow up. The patient actually doesn't have any symptoms. Now, there are certain patients where we need to do the surgery. The decision to intervene surgically in patients with ERM and VMT usually depends on the severity of the patient's symptom, especially the impact on their daily activities, reading or the driving problem or distortional changes. And it has been seen that patients with the VMT do not typically improve without vitrectomy when the VMT is a broad attachment that is greater than 1500 microns. Now, coming to a few surgeries, this is an VMT with an ERM, symptomatic patients. The basic steps which is different from an other vitrectomy is we need to separate the central part so that we don't induce any traction on the posterior pole and cause any macular damage. So once we separate, then the PVD becomes easier. I will forward it. So once we have separated and a little bit of tangential tool, we can release the traction from the posterior pole. As this patient had also an epiretinal membrane, we stained it with the BBG dye, removed the epiretinal membrane, and then did an alum peeling. So this was the pre-op and post-op, and there was improvement of 2 lines. So when the patient is symptomatic, the patient can feel the difference after the surgery. So this, there are a few VMTs which were symptomatic, we have operated, and it is the pre-op and post-op pictures. Now, this is an ERM which was causing distortion in vision. So even the OCT gives an idea of whether this ERM is globally attached or it is a loose. As in this case, you can see it is easily coming off, and it's very important you stain it again and see the remnant of ILM which is still there, and then you take it off. This is the pre-op and the post-op. And certain cases, the third case, there's a thick ERM and it's secondary to an RVO, and it can be in diabetic cases where we need not wait, we can directly go for the surgery. And as you can see, it's a very thick epiretinal membrane where we need to do the surgery as soon as possible. So to conclude the take-home message from this presentation, the majority of the ERM will remain relatively stable and will not require any surgery. Vitrectomy surgery is often indicated in patients who have a decrease in visual acuity, metamorphopsia, double vision, or difficulty using their eyes together. And generally, when it is symptomatic, vitrectomy really helps in terms of visual acuity, and it has been seen at least there is 2 lines improvement in the visual acuity when we operate on a symptomatic patient. Thank you.
Thank you, Dada. That was a wonderful presentation. One quick question, and after that, Dr. Bapai can, or even Dr. Vibhuti can. It's easier said that in case of focal VMT less than 1500 micron, that we have to induce and do a circumferential vitrectomy without pulling the one vitreous which is attached. It is theoretically, yes, even practically we do that, but whenever we try to do that, it is not possible all the time. And accidentally,
we should try at least.
accidentally,
It comes
we do
off.
see that it comes off, and most of the times we are lucky. The de-roofing doesn't happen. Is there
My
any
point
special
is
way?
that we should not go ahead and do the PVD as we do from the disc anterior posterior traction. So we should try to separate the vitreous from the central pole.
Exactly. Any other special technique if any panelist wants to talk about in case of inducing the PVD when the focal VMT less than 1500?
Yeah, if you see his videos, actually the vitreous along with that has come off.
Yes.
That is very dangerous thing to happen. You should go around and then trim it to the base.
No, I actually
closer to
forwarded
the-
it.
Yes.
I did that. And
so
in the
that
process, it actually separated out.
yeah, it will not come off actually. There is a layer which will folds by itself on the surface of the retina, and that you trim. The last chunk of it, you leave it.
And sometimes we need to do an ILM
Yes,
peeling if it is
yes.
very adherent.
When ILM
In
you
this
do,
case,
then
it
it
was
will
not
come off.
adherent. Sometimes it is very adherent and we have to do an ILM peeling for that.
100% you need to do ILM peeling. Only then it will comes off. That is the best thing that can happen. Even if a small hole happens also, it will close because macular hole principle is same.
Yeah. Now, I actually did an ILM peeling in that case as well.
I think most important thing is to stain the vitreous again and again to see where you are peeling the vitreous. And sometimes you accidentally pull the superficial layers off, and then you've already done the ILM peeling. But sir, a lot of times I am doing foveal sparing also nowadays.
Okay.
So the risk of not inducing macular formation.
But in a VMT,
In VMT, once you have cut through,
Okay.
all around,
No, no.
whatever is there falls back.
That is true, but at the same time, if you see the vitreous, anatomy of the vitreous, the central vitreous is very closely adherent and you should not leave that.
So, but once you have truncated from
No,
the
no,
fovea,
no. The vitreous
That's
should
what-
come off. It should come off.
One
from
thing
the
I do is
surface.
that I stain it and do not induce the PVD with the cutter. It's a very simple technique. You can use the forceps
Yeah.
and peel it like the ILM and make isolated island, and then you can use the cutter. And that's
in
very
many
simple.
cases, we need to do that.
Yeah, that is vitreous bursa that happens there, and you can clearly see after staining with steroid, and that need to come out. You should not leave it away.
Okay. So Dr. Bapai, Dr. Papuru, any last comment? Quick, because we need to give it to the international speakers. Any last comment?
No,
Dr.
I
Bapai?
think
Okay.
we should
We
give it.
should close the
And
session, and thank you very
yeah,
much.
Yeah. We are only 3 minutes late, even though we got it 40 minutes late.
It's because of Dr. Ajit Babu Maji, that is a very strict chairperson, moderator, and because of him, probably things will fall in line. Thank you,
Oh,
sir.
no,
for
no.
making it
You are
possible.
saying I'm a serious person. Don't consider him.
Can all the speakers, panelists, everybody join up on the stage for a picture?